Good afternoon, students. I do apologize that the collaborates that I initially put up on LMS did not work. I am now recording this on PowerPoint. I'm going to make a video and then upload it to a YouTube like I did the last two. I did get some of the administrative folks at RCC to try to make a last-ditch effort to save the videos on Collaborate, but they could not do it either. So I guess it's just not meant to be with that platform. So at any rate, we'll get started. This is chapter 25 in your Halter book, and it is on suicide and non-suicidal self-injury. And I'd like for you to make sure you read this chapter. It's not long, and it is, as the other chapters are, it is very, very good material, and it will do you a great service to go ahead and read it. And you can follow the PowerPoint slides without the voiceover or with the voiceover video as you go through it, but just go through the material thoroughly. But we're going to look at suicide first. So, how many of you have actually known someone who has committed suicide or who has contemplated suicide? Maybe maybe you have someone in your circle of friends or a family member of someone in your circle of friends, or maybe even in your family, inside of your family. So I think I have shared with y'all that my husband did have an uncle who, in his late 80s, committed suicide because he was experiencing hopelessness because he had come to the a point in his disease process and his I guess it was probably um, heart failure and also some pulmonary issues that they just could not do any more for him medically. So, and they told him that, and then he began to just lose hope. He got hopeless. He was very fatigued. He was exhausted from being in the hospital for about a week, and went home and used a gun to commit suicide. And his wife didn't even know he had a gun. Um, but I'm sure there were many cues that he had dropped. Little hints that he had probably dropped. Uh, he had been in the hospital for a week, so I'm sure that he had uh, made it known how hopeless he was. And as healthcare professionals, especially nurses who are at the front line with the patients, we need to pick up on that. We need to pay close attention and use our therapeutic communication skills to pick up on those cues. But per the CDC, in the year 2019, a human life ends in the United States every 11 minutes to suicide. And this is 129 lives lost daily. That was in 2019. Now, I do have, I looked up some more recent um, statistics today, and it was worldwide, it's every 43 seconds somebody commits suicide. So that is just horrible. But so we're going to move forward. So these are your objectives for today's module. And so I want you to look at those. And, it is a good thing to take those objectives and write them down and then answer them by, and, purging through your chapter 25 in Halter, and just answering these on paper. That will do you a world of good in regard to your test taking strategies. Okay, so a suicide attempt is engaging in potentially self-injurious behavior with the intention of death. So that is the definition. These attempts may result in death, injuries, or no injuries. Um, Sometimes suicide is not successful. But suicide is largely preventable and should be thought of as a never event. You know what a never event is. We learned that last semester. And too often we in the healthcare field focus only on those individuals who are at immediate risk. But in the year before their death, 83% of individuals who committed suicide were seen by a healthcare professional that could have picked up on cues. And we are taught to pick up on cues. We are taught the therapeutic techniques of communication. So we are supposed to be listening very well to our patients and picking up on nonverbal behavior. 54% of those individuals did not have a mental health diagnosis, and 50% of those who committed suicide made an appointment with a healthcare provider within 1 month of their death. So it is critical that we as healthcare professionals to be or become advocates for this problem and to mobilize the community to reduce factors that contribute to suicide, because it is a very big problem in all subgroups of society. Is all age groups. There are statistics for written in your text in chapter 25 for just about every age group, excluding the toddler. So I think beginning at age 10. So that should concern us as nurses very much. So let's go through these definitions again. Suicidal ideation, that is thinking about killing oneself. And so there are a lot of questions we ask people when they come into the clinics or the hospital setting, that we do an intake assessment. We ask questions about this. There are usually standard questions that we ask. Suicide attempt, the definition for that is engaging in a potentially self-injurious behavior with the intention of death. And then suicide is an intentional act of killing oneself by any means. Non-suicidal self-injury, this is intentional damage to one's own body tissue without conscious suicidal intent and for purposes not socially or culturally sanctioned. So in other words, this may be an effort to punish oneself for something that they feel that they're guilty of. But your text goes into great depth in this area toward the end of the chapter. So I want you to read that and be familiar with it, but we'll go through more of this as we move forward in this lecture. So for males, the suicide rate increased by 26% between 1999 and 2017. It is significant to note for females, the rate increased by 53% during the same time frame. So women account for suicide attempts about 1.4 times as often as men. So that's a changing trend in our society between 1999 and 2017. White males accounted for almost 70% of all suicidal deaths or all suicide deaths. So usually when men get it in their mind that they are going to be better off dead than alive, they usually make it happen. They usually are determined. They usually the statistics used to be that women attempted suicide more often, but men were successful more often. Now that's not true anymore. But substances are often associated with suicide. Toxicology tests in 16 states found that 33% tested positive for alcohol and 10% for marijuana and 4.6% for cocaine and then 20% for opiates or prescription painkillers. So that's your statistics for substances related to suicide. And then firearms were the most common method of death by suicide, accounting for a little more than half, or 50.7%, of all suicide deaths. The next most common methods were suffocation, including hangings at 27.72% and poisoning at 13.89%. Suicide rates increased from 1999 to 2017 for all races and ethnicity groups except for non-Hispanic Asian and Pacific Islander groups. Non-Hispanic American Indians or Alaska Natives had the highest suicide rates for both males and females in age groups from 15 to 44 years old. In 2017. And then in 2017, the highest United States age adjusted suicide rate was among whites at 15.85% at 15.85 per 100,000 people. Currently, Hispanics and Latinos have the lowest suicide rate among all racial and ethnic groups in the United States. In 2017, the highest suicide rate, which was 20.2 per 100,000, was among adults between the ages of 45 to 54, and this is the second highest rate that occurred in individuals 85 years and over at 20.1 per 100,000. I may need to rephrase that. Okay, so the highest suicide rate, which was 20.2 per 100,000, was among the adults between the ages of 45 to 54, and the second highest rate occurred in individuals aged 85 and over at 20.1 per 100,000. So that's not that much difference. So only 0.1% or 0.1 per 100,000. So suicide is the second leading cause of death among 10 to 14-year-olds and also among 15 to 24-year-olds and 25 to 34-year-olds. So you think about it, people in those age groups don't usually die at that age very often, but and mostly probably cancer or vehicle crash, automobile accidents probably, but not not thinking about suicide. But suicide is the second leading cause of death among these groups. So men aged 85 and older have the highest suicide rate of any group in the United States, and my husband's uncle was in that group. So the estimates indicate that in 2017, nearly 1.4 million adults aged 18 and older made a suicide attempt, and in 2015, approximately 575,000 people were treated in the emergency rooms for self-inflicted injuries. Approximately 7.4% of youths in grades 9 through 12 reported a suicide attempt in the last 12 months. And as I said, there is one suicide for every 25 attempted suicides. I think I said that earlier, but I want you to look at box 25.1 for more suicide facts in your text. And so here is a case study. So Gina is 14. She identifies as a transgender. She says, I have known since I was real little that I was meant to be a girl. I am a girl on the inside and always have been. As long as I'm of age, I'm going to get surgery for gender reassignment. I've been saving my money. I've been saving my money for that for as long as I can remember. In the meantime, I asked my friends to call me Gina uh, instead of Gino. I grew up with these same kids, so with my friends, it's really no big deal. Okay, so I do want to point out that recently, I know you've heard about this. Recently, a teenager won a lawsuit, won $2 million for transgender surgery when she was 16, and where they removed her breast. And now she's taken the people that did that to court, and she's won 2 million. One for 1 million for the psychologist or the psychiatrist, and 1 million for the surgeon. So just wanted to point that out. Okay, continuation of this case study. This year, however, things have changed a bit for Gina. Growing up in a small neighborhood school in the city, she has now entered a new, larger school. She doesn't always have classes with her friends, and she's beginning to get pushed around, excuse me, pushed around in the house. Recently, Gina, who dresses and grooms herself as a girl, tried to use the girls' bathroom, which was allowed at her small private school, but here a teacher followed her in and shooed her back out, calling her disgusting. And so now we look at some comorbidities. Psychiatric disorders are risk factors for suicide. Approximately 46% of people who die by suicide have previously been diagnosed with a mental illness. Major depressive disorders or substance use and psychosis are the diagnoses most commonly associated with suicide. Approximately 50% of those who complete suicide are experiencing a major depressive episode at the time of death. Individuals diagnosed with anxiety, personality, eating, and trauma-related disorders are also at greater risk for suicide. Loss of relationships, financial difficulty, and impulsivity are common precursors to suicide. And treating the coexisting psychiatric disorder may help most patients with suicidal ideation. 10 years after diagnosis, about 10% of individuals diagnosed with schizophrenia die by suicide. By 30 years after diagnosis, the incidence of suicide increases to 15% of those individuals. The depression is the most related symptom, not the delusions for these folks. And patients who have substance use disorder, both legal and illicit drugs, have a higher risk of suicide. Alcohol reduces inhibitions because it is a depressant. So if they're using alcohol, and sometimes they may be using more than one substance at the same time. Opiates, including heroin and prescription painkillers, are present in 27% of deaths by suicide, and alcohol is present in 41% of deaths by suicide. It does state in your text that there may be this incidence of suicide may be higher than what we think it is or what we know it is, because some suicide attempts are uh, they look like they're accidents, maybe car accidents, or even people with diabetes know how to give themselves more insulin than they need, just different things like that. Other drugs that are used, and we do know about the illicit drugs that are laced with fentanyl. Um, it's hard to say about those, because most of the time we don't suspect that they are trying to kill themselves, that we think that it is completely accidental. But there's a lot in your text that it goes into that is very, very interesting and very helpful, and very important that you read. Okay, so suicidal behavior is thought to run in families. One example that your text does highlight is that the Hemingways, the famous writer Ernest Hemingway, he had 5 suicides among 4 generations in his family. So neurobiological factors include low serotonin levels that are related to a depressed mood. So we know that the serotonin levels that the more you have, the more happy you feel. And how do we get more serotonin if we're feeling low? Well, physical exercise is actually a way to increase the serotonin level in your body and your brain, and then so that can bring about a feeling of wellness in folks. And I think I've told y'all this before. I know I've told some of the classes that have come through that physical activity does helps in a lot of different ways, but this is one way that it does help. And then the drug use or the substance use, we do know that if a person uses cocaine or other illicit drugs, there are other drugs that they use. If they use at one time, it wipes out the serotonin, almost all of it in the brain. And then the reason they get hooked is because they are trying to re-establish normality, how they felt before they used that drug the first time. And so the more they use it, the more it wipes out the serotonin in their brain. And the more they are wiped out, the more they try to use drugs to try to get that euphoric feeling or that even the normal feeling to return. But on your screen, the biological factors that impact suicidal ideation or suicide itself are could be genetic, could be neurobiological, could be cognitive factors, and also it could be environmental factors. So, think about environmental factors that cause people to be depressed. If someone in your family commits suicide, then that's going to cause a major depression among all of the family members. And you think about, and your text points out that most people have at least 60 people that are in their close friends and family members that their life touches. So if you think about the 60 people that your life touches, and if you do something that is going to really shake them up inside, shake up their very being of who they thought they were, who they thought you were, who they thought they came from, what's that gonna, how much of an impact is that going to have? So, other environmental factors could be any major stressor, and there are lists of major life stressors in people's lives. Even marriage, we think about that as being a happy time, but marriage is a stressor, even though it's a good stressor. But there are also a lot of bad stressors, such as divorce. That goes for the people being divorced as well as their children that they may have. Um, Other environmental stressors would be maybe a loss of a job or um, just a lot of different things. And we can talk about this in class about what stressors that you think could be stressors that could impact uh, suicidal ideation. Cultural factors and social factors, of course. Cultural factors would just be things like, what are the cultural norms? What are their friends doing? We do know that, when one youth commits suicide, there could be copycat suicides, and your text goes into that somewhat. So, we have cultural factors that shape our lives, and we cannot live in a bubble. We live, and everything that goes on around us shapes our lives and will impact. So, the social factors may be that someone is being bullied. So, that is a very real. We talked about that the last time we were in class, but that is a very real possibility these days. Twin and adoption studies suggest genetic factors are a causative factor in suicide. Concordance rates are higher among monozygotic or identical twins. And research has identified 4 genetic variants associated with suicide, and they are the SP110, the AGBL2, the SUCLA2, and the APH1B. I know that does not probably mean anything to you, but those are um, the genetic variants that are actually associated with suicide. So we have talked about the familial tendency uh, higher among identical twins and the importance of both genetic and epigenetic or external gene altering factors. So, and then we talked about the low serotonin levels. So all of those are um, things that impact the suicide of people, the incidence of suicide in folks. And so the cognitive factors, we're going to talk about that some. Research has found low levels of serotonin or the metabolites of serotonin in cerebrospinal fluid of patients who are suicidal. Post-mortem examination of individuals who die by suicide are also reveal low serotonin levels in the brainstem and the frontal cortex. And then cognitive factors, Sigmund Freud originally theorized that suicide resulted from unacceptable aggression toward another person that had been turned inward. And we do know through studies other than Freud that males tend to turn their anger outward, and females tend to turn their anger inward. Um, but sometimes males do turn their anger inward. Um, but that is just something that is harsh on our bodies and our minds. The anger, we need to get rid of anger. We need to not let the sun go down on our anger. There are a lot of proverbs that are very wise, and we don't need to internalize anger. We need to work that anger out. We need to be forgiving of others, and because the anger can destroy us more than we know, and even if the anger if the anger is a valid response to something, it's still not healthy. But Carl Menninger added to research to this study, to this knowledge base, and he identified aspects of suicidal hostility, and things such as revenge, guilt, and hopelessness do factor in to suicidal ideation. Hopelessness and rigid thinking. Rigid thinking is like all or nothing. It can't be fluid, it can't be flexible. So this is the inability to see different opinions and having perfectionism. All of this has been cited as components of suicide. So it's really not a good thing to be a perfectionist. It's a good thing to admit that, no one is perfect, and uh, we need to have grace with ourselves and with others. And that's a better way of thinking. It's a more healthy way of thinking. So environmental factors, these are conflicts within families and neglect through low parental monitoring, and they are associated with childhood suicidality. Um, and then the physical, the sexual, and emotional abuse, parents in prison, family history of suicide, increased risk for suicidal ideation, and attempts in adulthood by uh, this. Uh, this increases it to up to 2.7 times. All of these factors increase suicide up to 2.7 times. So think about when you were a child and your parents had an argument, or um, anybody in your family had an argument, how much it might have bothered you. Think about that. Think about how those vulnerable children internalize that, and then as they grow to be adults, what kinds of impact that has on them as adults. So the suicide of a relative, a peer, an idol, or public figure may result in a cluster suicide or cluster suicides or contagion suicides, and they're also called copycat suicides. So this has happened. It's documented that it's happened. Adolescents are more high risk because of the immature prefrontal cortex, and this is a portion of the brain that controls the executive functions involving judgment, frustration, tolerance, and impulse control. Cultural factors such as religious beliefs, family values, sexual orientation, gender identity, bullying behavior, and attitude toward death impact the suicide rate also. Protective factors do include religion and the role of the extended family. Social factors are spoken to in your text on table 25.1 on page 474. Relationship problems, crisis in the past or upcoming weeks, substance use, physical health problems, job and financial problems, criminal and legal problems, and loss of housing. How many homeless people do we have just right around us? Think about that. Other social factors include social media, assisted suicide. Some states have laws allowing assisted suicide, and some countries do. Um, I did look up the countries that do have the law that allows assisted suicide, and it's not the United States, but we do have some states that are um, that are moving in that direction. Suicide bombing is another issue, and psychological autopsies are retrospective reviews of the deceased person's life within several months of death to establish likely diagnoses at the time of death. And you can look at box 25.2 for warning factors, risk factors, and protective factors. And I would encourage you to do that, to star that box and review that before your test. Okay, so these are the environmental factors, and adolescents are especially high risk due to their immature prefrontal cortex. We said that, and the portion of the brain. This is the portion of the brain that controls the executive functions involving judgment, also frustration tolerance and impulse control. And so the adolescents are very much out of control when it comes to impulses. They are unpredictable with some of these impulses, so they have a tendency to act on their impulses and believe that they are, they are not going to sustain any permanent injury. Sometimes they believe they're invincible. Sometimes, so I'm not sure how that factors into suicide, but they do tend to believe that they are invincible. So that probably uh, impacts the suicide rate in adolescents. So research has found low levels of serotonin or the metabolites of serotonin in cerebrospinal fluid of patients who are suicidal. Post-mortem examinations of individuals who die by suicide also reveal low serotonin levels in the brainstem and the frontal cortex. The cognitive factors, we talked about Sigmund Freud. He originally theorized that suicide resulted from unaccepted aggression toward another person that had been turned inward. We talked about Carl Menninger, who added to that research, identifying aspects of suicidal hostility, also revenge, guilt, and hopelessness. We talked about the rigid thinking, and we talked about the environmental factors. There is a table 25.1 on page 474, and don't forget box 25.2 on on that page also. So don't forget that one. Okay, these are cultural factors. Research has found low levels of serotonin or the metabolites of serotonin in the cerebrospinal fluid of patients who are suicidal. We talked about, let's see. So I did touch on this, but cultural factors such as religious beliefs, family values, sexual orientation, and gender identity and bullying behavior. Also, attitude toward death. All of these things impact the suicidal rate or the suicide rate. And also, if there is a culture, many of you I know have cultural values that value your religion, your belief, your spiritual beliefs, and the role of your extended family. Many of you, I've heard you talk about, your extended family, your grandparents, your parents, your aunts, uncles, cousins, um, and you have a very close-knit family and extended family. Well, if you have those relationships in your family, that's a protective um, factor. So that is very good. But I want you to look at the social factors on table 25.1 on page 474. I want you to look at that and know that. And here we are on social factors. And let's see. So we have social media now that we didn't have a, as much of a few years ago or several years ago. There are even some movies or television shows or websites that talk about suicide, and that children and teenagers and adolescents who don't have that maturity and do have those impulsive behaviors, they are very susceptible to listening and believing some of this information that they get on social media or some of these television shows or some of these websites. And some states have laws allowing assisted suicide, and some countries do. We said that. Suicide bombing is another whole issue. Um, but I want you to look at box 25.2 for warning factors of suicide and risk factors, as well as the protective factors that we talked about. But on this slide, we do have relationship problems that could be a problem that would impact a person to look at suicide as a way out. Recent or imminent crisis situations, substance use, health problems, financial problems, legal problems, and loss of housing is a big problem. So look at all of those things in the box. Family history of child maltreatment. Adverse childhood events would impact the suicidal ideology or the suicidal tendencies in adolescents. Look at their their previous suicide attempts, and their history of mental disorders, particularly clinical depression. That is a very, very deep depression, and that requires treatment by a medical professional. So look at that history, if there is any, and then the history of alcohol and substance abuse disorder. I said feelings of hopelessness and impulsive or aggressive tendencies. So all of those things I want you to examine, read about in your text, and remember. Okay, so this slide, this just gives you objectives to what we're going to be looking at next. We need to identify the evidence-based practice for suicide risk, and also the assessment tools to to measure the suicide risk, and then discuss the basic level of interventions to address suicidality in the hospital or in the community setting. So you will have tools to use to uh, their their like surveys that you use, and then you add up the points based on their response, and whatever number you come up with, you have a, a, a measurement tool to decide where they are on that continuum of no suicide thoughts to suicide thoughts. So, and then you can explain the key elements of suicide, precautions, and the environmental safety factors in the hospital setting. So we're focusing on the hospital setting. And here are some objectives moving forward. We're going to describe 3 expected reactions a nurse may experience when working with patients who have suicidal ideation, and then identify biological treatments and psychological therapies for patients with suicidal ideation. So suicide risk assessment is based on identification of risk factors and protective factors, and taking a psychosocial and health history, and establishing a therapeutic relationship between the nurse and the client. And that is what you're becoming an expert on, is your therapeutic communication, and just building that therapeutic relationship so that you can impact that patient's health and their mental health in these cases. So the nurse would usually complete the assessment in collaboration with other clinicians in order to compare their data and their impressions from 2 or more evaluations. Assessment tools are helpful in providing a baseline evaluation. So you have the suicidal assessment, 5-step evaluation, and triage, and that's abbreviated as SAFE-T, SAFE-T. And this tool assists for benchmark relative risk, and it can be high, moderate, or low, and then develop a treatment plan. Also, the Columbia Suicide Severity Rating Scale, the C-SSRS, is recommended as well. And so what are the overt and covert statements used by patients? I want you to go through the list here on the side. So we have your assessment, the verbal and nonverbal cues. We have overt statements, covert statements, nonverbal cues. So think about the way a patient may be giving these statements and cues. And then think about how, if they have a plan, do they have a plan? Excuse me, I'm so sorry. Do they have a plan? And if they have a plan, how lethal is that plan? So is it a gun? That's pretty lethal. Is it other modes of suicide would be suffocation, which would include hanging. And then there is the breathing in of carbon monoxide in from a car that you intentionally set the car up where it's running and the exhaust comes back in the car. And then we have also, taking pills. And you already know that you have to have the patient open their mouth and make sure they're not saving the pills or hoarding them. Some of these patients that are on suicide risk precautions could be hoarding them to take all at once. So you need to really pay attention. I have noticed that y'all do this in the clinical setting. You do ask them to open their mouth, and you search their mouth to make sure they've swallowed the pill. That's very reassuring. I love that. I love seeing that. That's awesome. And then you need to get a history of their attempts, and then you also need to get their family history. And remember, we did not too long ago. We did the genealogy, where you wrote out, you drew out your family in at least three generations, and then you documented if they had health problems or if they were deceased and how they died. Um, if you pick up on a history a family history of suicide, then that's an important thing that you should take in consideration and that you should document that. Also, sudden switches from sad to a happy mood. This, a lot of times, this makes us feel very reassured, but sometimes it's not so reassuring because sometimes they have planned to commit suicide and they have solved their problem. They're going to commit suicide and solve all of their problems. And um, so they'll start giving away very treasured things, material things. They'll start giving those things away and feeling happier than they've been. So that might feel like a good thing, but it's a lot of times it's not a good thing. A lot of times it signals that they have made a definitive decision to commit suicide. And then you have your social supports. We need to make sure we know that they do have social supports and who they are. Okay, so this is a discussion question. You are worried about a close friend who recently broke up with a boyfriend. She is taking the breakup very hard and seems very depressed. What are some questions you could ask this friend to assess for suicide ideation? Well, in class we're gonna get your responses, but for right now, some of the things that you could ask: have you ever felt like life was not worth living? Have you been thinking about death recently? Did you ever think about suicide? Have you ever attempted suicide? And do you have a plan for completing suicide? You wouldn't ask them this fast, but you would ask these questions. You would ask these types of questions. If they do have a plan, what is your plan for suicide? And we would think that when we ask these questions, it might push them to suicide. It might seem like we're suggesting that they commit suicide, but that's not, research shows that that's not the case. Research shows that if a person is or has had suicidal ideations, that they are relieved that someone is asking these questions and it's very helpful to them, but it's also helpful to us as nurses and as healthcare professionals to find out how they're thinking so that they can be treated and we can intervene with that. Okay, so as nurses working with patients and clients who experience suicidal ideation, it is important that we collaborate with other nurses and clinicians. Nurses can develop feelings of fear, grief, anger, puzzlement, condemnation, of suicide feelings are some common emotions that we can experience. So it's very hard on nurses to deal with people who have suicidal tendencies or suicidal thoughts. And it's important that we recognize this and work through them. Um, and so we need to consider what is countertransference. Transference. This is when the clinician's feelings and desires are unconsciously redirected onto our patient. And this can occur with nurses. And in this phenomenon, the clinician lets their own feelings shape the way they interact with or react to their client in therapy. So we have to recognize this and we have to consider that it could happen. And so that's why it's very, very important that we as nurses, especially when we're dealing with mental health issues with patients, that we have an open dialogue with our fellow nurses and maybe have it would be good even to have a mentor that we could go to and talk this out. And I know in the nursing world we don't have a whole lot of time to do this, but I think it's important that we try to make time for this. So think about that too. And then the highest priority in nursing diagnosis is risk for suicide. Others related to depressed mood include self-care deficit, impaired sleep, impaired nutritional intake, also anxiety. And the outcome we want in these patients is decreased risk for suicide. I want you to take note of table 25.2 for signs and symptoms and potential nursing diagnoses and the outcomes that we want. The plan of care for the patient with suicidal ideation is based on risk and protective factors. So when there is a comorbid psychiatric disorder, the treatment plan includes appropriate nursing approaches, and we need to include significant others in the plan of care because the patient's perception of isolation is a significant cause of hopelessness. So we need to bring others in to help us with these, with the application of the nursing process. So, and we need to collaborate with others, including the patient's family. Okay, so in regard to implementation and evaluation, we do know that this is a circular, not a linear type of process. We continue the process until until something is resolved, or it may never be resolved, and we have to continue the process to help the patient and continuing to assess and evaluate and implement. And so for implementation and evaluation, we need to focus on prevention, treatment, and postvention. Prevention is primary intervention that provides support, information, education, and that is all to prevent suicide. It is rare that a patient could overdose on a SSRI, selective serotonin reuptake inhibitor. However, the overdosing remains a concern for the tricyclic antidepressants and monoamine oxidase inhibitors. So the SSRIs are the first line treatment. And so many times that's what you'll see the patients on, especially if they're young. And it may be important to conduct mouth checks, as I said earlier, to ensure that the patients are not saving or hoarding medications in the hospital in order to attempt an overdose at a later time. Health teaching is paramount in regard to medications and diagnoses and complementary therapies and age-related developmental crises. So community resources and building coping skills and stress management and communication skills, all of these things are so important that we could teach the patient as nurses. Also, the teaching of a safety plan development is important in preventing suicide, and so the family would be involved in that teaching. To strengthen the support system, I want you to look at table 25.3 for a general description of suicidal precautions. It is important to note and document the patient's affect at each assessment. The affect could be hostile or fearful. It could be calm. So we need to document that. We need to assess that and then document it every time we have an interaction with the patient. Box 25.4 has guidelines on how to minimize physical risk in the environment. So we have to look at things that could potentially be a tool to commit suicide. Unfortunately, we have to look at that. Postvention is what providers are often involved in when providing mental health care and support to survivors whose family member has been successful in the attempt of suicide. They've been successful in killing themselves. So the postvention is what we do to treat the survivors. The survivor becomes the patient at that point. So we focus on their thoughts and feelings, and we assess the patient as we normally would. The most difficult time for survivors is not immediately after the death of their loved one, but in the weeks and months and years following their loss. Anniversary dates are important and most difficult. Don't be afraid of talking about the deceased person. Talking reduces the hurt and isolation. It reduces their isolation about the incident and the stigma. So it's very good to talk about it. You would think not, but it is. Documentation is critical, especially in the case of successful suicide attempts by the patient. Staff are traumatized also by the suicide and may experience post-traumatic stress disorder with guilt, shock, anger, shame, and decreased self-esteem. And the overlooked clues will be identified, uh, faulty judgments or changes that are needed in agency protocols. We may look at that. I do know of an incident that happened at UNC Southeastern where a patient did commit suicide. He was not from our area. He was traveling through, came in off of I-95. I'm not sure how he got to the hospital, but he did. And he was on suicidal risk precautions. They had a sitter with him. I knew the sitter, and the patient jumped out the window, and the sitter could not prevent it. And I'm not sure how he was so strong to do that because the windows are not, they're not to where they can be opened or anything, but this occurred. It was a never event that occurred, and it was horrifying. And it did cause a lot of people a lot of pain, even though, nobody knew him. Nobody here knew him, but it caused a lot of pain. But anyway, know your facility's policy and speaking with family members. In most cases, the facility will recommend a designated spokesperson that can address the feelings of the family without discussing the details of the patient's care. And referrals may be given to family members to assist in dealing with their grief. Evaluation of suicidal ideation is ongoing, and close monitoring is important, and teaching on the benefits and risks of antidepressant therapy. Of course, we would have to do the medication teaching because that's so important. Okay, so environmental safety guidelines, this is just a list, and this is spoken to in your text. We need to use and count plastic utensils. No private room is is encouraged. We encourage the patient to be with people. Keep the door open at all times. We need a jump-proof and hang-proof bathroom. Lock the doors to non-patient areas because they don't need to be, searching for things that they could use to harm themselves with. Monitor for and remove potentially harmful gifts that are brought in. Unintentionally giving, they may be unintentional things that could harm them, and we just don't think about things like things that we give people. We don't think about them thinking that they could harm themselves with them, but they probably could. In patients' presence, assess their belongings and search the patient for harmful objects because they could be hiding something. And then ensure that the patients do not bring or leave harmful objects. Um, so those are your guidelines for safety. And the psychiatric, excuse me, the psychiatric mental health advanced practice registered nurse may treat patients with suicidal ideation directly with psychotherapy, psychobiological interventions, clinical supervision for direct care staff, or consultation in non-psychiatric setting. And this could include the healthcare unit, the nursing home, or forensic site. And then following the hospitalization, the advanced practice nurse may provide aftercare for the patient who has coexisting psychiatric disorders, and this care includes individual and family therapy and medication management. Um, and so when I was a student at Duke, we did have professors that were very much encouraging nurses to go into psychiatric nurse practitioner uh, trajectories in Duke at Duke School of Nursing, but they were predicting that due to substance use, they were going to have a whole lot of need for the advanced nurse practitioner in the area of psychiatric and mental health. But that's just something to throw out there in case you're interested in thinking about that. Um, and they do have scholarships, a lot of scholarships available usually for those under underutilized advanced degrees for nurses. Okay, so this is a case study continued. Gina is hospitalized for suicidal ideation after 2 suicide attempts. For the first 2 days of hospitalization, the patient eats 20% of meals and stays in her room between groups. By the 4th day, the nurse observes that the patient is more sociable, is eating meals, and has a bright affect. So, considering Gina's behavior on the 4th day of hospitalization, which factors should the nurse consider? A, the patient is showing improvement and may be ready for discharge. B, the patient may have decided to commit suicide. The nurse should reassess suicidality. C, the patient is feeling rested, supported by the therapeutic milieu, and less depressed. Or D, the patient is benefiting from the antidepressant she has been taking for 4 days. And I want to advise you to remember your pharmacology and what we learned last semester about the time frame that antidepressants take before they are affected. So the answer here is B. Both the assessment guidelines box and table 25.3 talk about dramatic mood changes being a high risk factor, and that includes sudden upswings in mood. It is always wise to consider the possibility that a patient who is recently suicidal may be exhibiting positive traits because he or she is at peace with a final suicide decision and is feeling relief or even exhilaration about this. So do not just assume that they are immediately better until you have had more time for observation. And again, remember the time that the antidepressants take in order to work. It's not immediate. It's not just a couple of days or 4 days. It usually takes at least 2 weeks for them to get into the system. So remember that guideline with your pharmacology. Okay, so here are more objectives for you. Describe the non-suicidal so, self-injury in terms of clinical pictures. So now the epidemiology, of course, and comorbidity and all of the factors, related factors, the risk factors, and then discuss the nursing care for patients with non-suicidal self-injury and identify the biological treatments and psychological therapies for patients with non-suicidal self-injury. So we're going to look at this for a minute. Okay, so the prevalence of the non-suicidal self-injury disorder is between 6 to 23% of the U.S. population, and they will engage in these behaviors at some time in their life in that percentage of our population. So about 15% of these are adolescents, and 17 to 35% of college students engage in injurious behavior. And to me, when I first realized that this was going on, and even my son mentioned it to me when he was in college and in high school, it just horrified me. And I just could not imagine why people in that age group were doing these things. But you think about what children go through, and sometimes it's abuse, sometimes it's bullying, sometimes it's neglect. I mean, all of the things that we talked about earlier, these children are going through, and they are very much impacted by it. But so this disorder peaks between 20 to 29 years of age if they start it in their early years. In adolescence, then it becomes very prevalent in their life between the ages of 20 and 29. And then it declines in early adulthood. And the ratio of females to males with this disorder is 3 to 1 or 4 to 1. So it's very much prevalent in the females as opposed to the males. And again, it's sometimes it's about punishing themselves. So when working with a patient or client who is at risk for suicide or has attempted suicide, an open discussion of the incidence, the prevalence, and factors associated with suicide attempt and non-suicidal self-injury, we need to have that discussion. We need to have that realization, and this decreases stigma associated with the behavior. So traumatic events may be a trigger, so it's important to monitor in order to manage this. Also, a thorough history of the patient's self-injurious behavior. The type of behavior, is it cutting, or what is it? It can be a lot of different things. The frequency that it occurs, the motivation for the behavior. Also ask what has worked effectively in stopping or decreasing the behavior in the past. Appropriate assessment of wounds that they have from this behavior is also important to plan care for the patient. And then nurses for patients who are engaging in self-injury report that they are affected emotionally while caring for these patients. Obviously, they would be. Nurses may feel defeated when patients relapse. They feel discouraged. They feel powerless to assist or intervene in the overall recovery of the patients. And this may lead to burnout of the nurse. So transference may occur where a patient projects the patient's emotions on the nurse. And establishing appropriate professional boundaries with the patient is important for your self-care as a nurse, as is collaboration with other clinicians. And we just talked about this with the other actual suicide and the suicide attempts of patients. So this is also important with this disorder. The highest priority nursing diagnosis is risk for self-mutilation or self-mutilation, and patients may experience anxiety, tension, self-loathing, and also nursing diagnoses that are appropriate for underlying comorbid psychiatric conditions, maybe major depressive disorder, bipolar disorder, borderline personality disorder, which we studied recently. So all of these may be indicated. So our outcomes are aimed at removing the risk of self-injury. Therefore, an overall outcome is that the patient will experience no self-mutilation within a determined time period. And the goals to meet this outcome may include patient refrains from obtaining tools for self-injury, request assistance from staff as needed, use available support groups, and uses prescribed medication as ordered, and identifies alternative coping strategies. So all of these are good nursing diagnoses. And I apologize for my voice going. This is about the planning for the patient, and it includes the demonstration of a caring attitude on the nurse's part toward the patient, bearing hope for the patient's recovery, observing for signs of self-harm, and anticipating potential triggers, that there are potential triggers, and evaluating the need for medication and providing appropriate interventions for the patient's wounds and their injuries. And we need to engage the patient and their plan in the 6-step approach to recovery. So the 6-step approach includes limit setting for safety, developing self-esteem, discovery of motive and its role, and then discovering self-control, replacement with coping skills, and entering maintenance phase. So we want to not to let them relapse into engaging in this self-mutilation. So we want to maintain their state of not self-mutilating. So this is the application of the nursing process. The implementation will include caring for their injuries, establishing a therapeutic alliance with the patient, teaching coping skills, and promoting reflective dialogue. Let them reflect. Let them use reflection to kind of see how they've been, progressing, and how look at their small baby steps of improvement, and focus on the positive. And then evaluation would be to continue to evaluate the patient's communication and perception of their own state of mental health or illness. But so this is part of what we're going to be doing as nurses with these patients. And it's important that you thoroughly read your text to get the full information of what we're talking about here. We'll talk about it in class. Okay, so treatment modalities, they do include the advanced practice psychiatric mental health registered nurse, working with patients who use self-injury to cope, and we want to turn that around. Specific therapies that are used include cognitive behavioral therapy. This is, we've looked at this therapy before, so you know what this is. Also, dialectical behavior therapy. You've also seen this with your personality disorders. Group therapy and dialectical behavioral. That's a duplicate there, sorry. All of these involve reducing emotional dysregulation and increased stimulus control. Suicidal ideation often accompanies some forms of drugs that are used. So it's important that patients learn to use more healthy coping mechanisms and to decrease their destructive behavior. So we want to work with them on all of that. And so this is a question. So which method of suicide has the highest lethality? And A is ingesting pills, B is cutting one's wrist, C is inhaling natural gas, or D is self-inflicted gunshot wound. So which do you think? So it is D, a self-inflicted gunshot wound. So again, if the patient has a plan, we want to know about it, and we want to know what the plan is and determine and how lethal the plan is. Um, the gunshot wound is considered a high-risk method, or sometimes it's called a hard method. And the other examples listed here are lower risk, and they're sometimes called soft methods. So, so that is the end of my lecture. We'll talk a lot in class next Tuesday, and I look forward to hearing about your thoughts on this topic, because a lot of times a lot of young people know a lot about this topic, and I just look forward to interacting with you, and I will see you on Tuesday. Thank you.